All right, here you go. Welcome to, I think it's our 6th session in this educational series, and we're going to be talking about quantitative methods today, and it'll be presented by myself, Shayna, and Nick, who you're going to get to know in a lot of parts of the presentation. Oops, hold on. My screen is not advanced. Why are you not? Hold on, for some reason it's not advancing. There we go. So we are the Evans Center for Implementation and Improvement Sciences. We are a methodological hub for IS in safety net settings. We can provide guidance and support on your research design. We can help you with your qualitative methods, your quantitative methods, and you can engage with us through these educational seminars and through research consultations, and you can reach us via email or via our website. We are led by Marilyn Benoni. She's our director. We have 2 co-associate directors, Kirsten and Nick. Santana is our assistant director, and Kayla is a research specialist. We have both present and past fellows that are part of the team. We have Gabby and Catherine and myself, and we have our current fellows as well, May and Katie. And speaking of our fellowship, if you are interested, our fellowship application is live. Applications are due March 15th. You can do your application by going onto the website to find out what needs to be done. You can scan our QR code, and please feel free to reach out to us if you have any questions. Santana will be able to help you with any questions that you may have, and she has also put the link in the chat. So we have 2 more sessions left in our series for the semester. After our quant methods, we'll be doing fidelity and adaptation in March, qualitative and mixed methods in April. So the learning objectives for today, and just as a caveat, if at any point in time you have any questions, feel free to interrupt me, put your question in the chat. Santana or Kayla should see it and alert me to that. If you have any questions, feel free to interrupt. So for today, we want to focus on understanding the types of errors that quantitative methods can address, describe some common quantitative measures that you probably come across and you'll be using in your research, and understand how you pair your methods with your study design and your question, as well as use some case studies to just show these methods in action. So the first thing we're going to do is kind of talk about what are quantitative methods, when you use them, and how we use them to address bias and uncertainty. So why quantitative methods? So when you use these methods, you're answering the question from your data, how much? So what has been the impact of your intervention on the outcome of interest? And with what certainty? Like how certain are you that the result that you get is representative of the sample and the underlying population? So there are 3 main purposes of quantitative measures. You want to estimate a quantifiable truth. And I'm going to explain that a little bit more in a later slide. So you want to kind of estimate a quantifiable truth about your population from your sample. So you can do that by measuring associations, proportions, or differences. The other thing you can use quantitative measures to do is to define the confidence around your measures. So we're going to get into that, talk about the error and talk about the bias that could be associated with your estimate. And then we also use these measures to test hypotheses about whether your quantities differ. So do means in different groups that get different treatments differ, and if there's an association between your intervention and your outcome. So when we're thinking about quantitative methods and the types of error we can address, there are 2 types of broad categories. You have random error, and that impacts the certainty of your estimate. And the certainty of your estimate is kind of, you can indicate it by your standard deviations and your confidence intervals. And then you have systematic error, and that's the accuracy of your estimate. So how close is your estimate to the real truth? And that's impacted by different forms of bias and confounding. And study design and analysis can deal with both types of errors. So it's actually really important to have a strong study design and an appropriate analysis for the design of your study. So we're going to start about random error first. So I previously mentioned that you use your quantitative measures to estimate a quantifiable truth. And that's because we never know what the true answer is. You never know what the true prevalence of something, a disease is in your population, because it is impossible to measure it in the entire population of a country or of the world. So you use your study design and your analysis to kind of estimate what your value is. And so you can only say, is my estimate precise or is it imprecise? And that is, if you were to repeat your study multiple times, are you getting the same result? Or are you getting results that are all over the place? And so the random error is the amount of precision in your estimate, and you can reduce it by repeating your studies. So often you'd be reading literature, reading a paper, and you're going to see that somebody did a study that somebody else did, but they did it in a different population or in a different location. And you want to see if when you repeat this study different times, what is the result you're getting? And some ways that you can reduce this random error is by increasing your sample size, or just putting things in your actual study design that reduces variation in response and variations in the way you measure things. But, you know, that's not always possible. And so it's important to have the correct analysis as well. So when we're thinking about random error, as I said, you're thinking about the variance of your estimate, your standard deviation, and your confidence intervals, because they can kind of reflect the range of values. And we're going to get into how you use and interpret these measures of random error when we get further into the presentation. So the next type of error is going to be systematic error. So is your best estimate actually correct? And the types of things that cause systematic error are going to be like selection bias. So if you harken back to our study design presentation, we talked a lot about different types of error and how they impact your results. So you have your selection bias, and that's when you have like systematic differences between your sample and your underlying population. Misclassification bias, where your participants are incorrectly categorized as either exposed or not exposed. And confounding, which is something that you hear about all the time and we talk about constantly because it's such an important factor that really impacts the results of your study. So we're going to do a quick recap on confounding, since we're going to talk about it a lot in this presentation. So it occurs when you have a variable that is associated with both your exposure and your outcome. So if you're thinking about, this is what's going to be an example I made up. So if you're interested in looking at the relationship between coffee and cancer, for example, and you don't adjust for smoking, you're going to have a biased estimate. So because what happens is that people that drink a lot of coffee also maybe tend to smoke, and smoking also causes cancer. And if you don't adjust for this fact, then you're not going to get a true estimate of the impact of coffee on cancer. And there are ways to account for this in your analysis, and there are ways to account for this in your study design. So you can restrict your analysis to just people who don't smoke, just to make sure that your result is not being impacted by smoking, or you can do something like randomization, which in theory takes care of a lot of measured and unmeasured confounding in your study. So just as a quick summary before we move on, there are two types of big errors: your random error and your systematic error. And we never really know what our true estimate is. We can just know if our estimates are precise or if they're not precise. And we can use our statistical analyses to account for both types of error. Any questions before I move on? Great. So the next thing we're going to talk about is choosing a statistical approach. Now, your statistical approach is going to be determined by your study design, your type of outcome, the question you're asking. So we're going to do a quick little exercise where we're going to kind of match the study question to the type of outcome and the type of test you would use to examine that outcome. And if anybody knows the answer and wants to participate, please feel free to jump in, either unmute yourself or write in the chat. So our first question: does the use of beta blockers reduce the length of stay? So length of stay is your outcome in hospitalized adult patients with acute MI. What kind of outcome is that going to be? I'll tell you. It's a continuous outcome. And if our question is, what is the relationship between administration of antibiotics and acute liver failure? So this is, did you have liver failure? Yes, no. That's going to give us a categorical outcome. And if you're asking, how many migraine headaches did my patient have in a clinic per week? That's going to be a count outcome. And if you want to, so does Ozempic reduce BMI? That's going to be continuous, because BMI is a continuous variable. If you want to know the number of violent incidents in a 6-month period by patients in a psychiatric ED, that's going to be count. And if you want to know if somebody received corticosteroids, yes or no, after an intervention, that's going to be categorical. And I'll take a minute here just because I don't know if other people have this question, but I know when I first started out, I would always struggle sometimes between a continuous variable and a count variable. And one thing that a professor told me that I found really helpful was that for count variables, your outcome is usually pretty discrete. So did my patient have a headache today? Yes, no. If it's yes, that counts as 1. Whereas something like BMI is continuous. So it's not a discrete thing. It's always present. It's not going to be present or not present on a given day. So your type of outcome then is going to determine the type of testing you're going to do, as well as other factors. So if you have a continuous outcome, there are different kinds of tests. These are both adjusted and unadjusted things that you can do. You can do a Kruskal-Wallis, you can do a t-test, you can do an ANOVA, you can do a linear regression. If you have a categorical outcome, you can do a chi-square, you can do a logistic regression. If you have a count outcome, you can do a Poisson regression. Now, this is just a real quick overview, but your test type is also going to be determined by how, if your data is normally distributed or not normally distributed, if you have small cell sizes, that kind of thing. But this is a quick overview of tests that you can do. So when you're finally to the point where you're planning your analysis, you have a few steps that you want to go through. The first thing you're going to want to do after you have your study design, you have your question, you know what kind of outcome you have, you want to determine, you want to examine the distribution of your continuous and categorical variables. Your baseline variables, the variables are going to be included in your analysis. And this first step is super important because it allows you to assess if you have any missingness in your data, because the level of missingness can also lead to bias in your study if certain variables that are missing are potential confounders, or if people who are missing data tend to be different from the people who are not missing data. It allows you to assess the normality, like the distribution of your variables. And that also is going to inform which kind of test you use. Are you going to use a test that can analyze normally distributed data? Are you going to use a test that analyzes non-parametric data? And it also allows you to determine, do you have sparse data? Is there something that you measured, like how many people went to the store this week? Only 2 people went to the store. So if you have a really small sample size, it's going to tell you, can I use this measure in my analysis, or am I going to need to do some kind of like change what my plan was? And when you're at this step, this is called your descriptive analyses. You're going to look at means and medians if you have like a continuous variable, and you're going to look at like proportions and rates if you have a categorical variable. And you, again, examine these distribution by some of those tests that I went over, your t-test, your ANOVAs, your Kruskal-Wallis. And again, the test that you choose is going to be based on how normally your data is distributed. If you're comparing 1 group, 2 groups, 3 groups, more groups, and you do that first step, and then you kind of move on to looking at associations. So if you're looking at an association, you're going to then going into the adjusted analyses part of your plan. And just as a caveat, as I move forward through this part about adjusted analyses, we're going to use a regression analysis as the example, just because it's one of the ones that's most commonly used. But please note there are other things that you can do, a much more higher level regression analyses that can be done. So quick review on a regression analysis. So a regression model literally just estimates the relationship between your dependent variable, just say, I don't know, BMI, and your independent variable, say it's like Ozempic. And you can have either linear regressions, which you use when you have a continuous outcome, and you have logistic regression when you have like a binary categorical outcome. And all your regression line is this line a best fit? So then think back to the beginning when we were talking about error. So what your line does is the line that when you draw it through all of the points of your data, it minimizes the distance between your predicted outcome and the actual outcome. So you're trying your best to kind of like reduce error in your model with your line of best fit. So the next thing we do is we examined our baseline variables. We looked at our distribution of our variables. We've decided we're doing an adjusted model, and we're going to do a regression. All right, so now we're going to start building our model. And what you want to do is you're going to assess for your variables to see if you have a confounder in your variable, a confounder in your analyses that you need to adjust for. And there are multiple ways that you can do this. One of the ways that's pretty common is just looking at if there's a change in your estimate. So let's again use the example of BMI and Ozempic. You want to have BMI, you want to have Ozempic, and then you want to say, does your height also matter? Is that like confounding your, or if you exercise, is exercise the confounder relationship between Ozempic and BMI? And what you do is you'd add exercise to your model, and you'll see how the size of your estimate, your initial estimate between BMI and Ozempic changes once you add exercise to the model. So some people say if there's a 10% change in my estimate, then this is probably a confounder, and I want to keep it in my final analyses. Some people decide, no, it needs to be a 20% change before it can be considered a confounder. And that's all something that you need to decide prior to your actual, when you actually start your analysis. One of the other things that is important is clinical plausibility. So there's always a discussion when you're doing analyses between what is statistically significant and what's clinically significant. And so there are going to be variables that might not have a statistical significant impact on your result, but in discussions with your team, the clinician, the subject matter expert, they're just like, this is a clinically relevant variable, it needs to be in your model. And in my experience, a lot of times those variables, even if they don't change the size of the estimate itself, they make my estimate more precise. So they like reduce my variance or my standard deviation or my confidence intervals. And just as a caveat with confounding, you can only adjust for things that you've measured. So if you've not collected data on a potential confounder, then you cannot adjust for it in your model. And this results in what we call unmeasured confounding. And it's one of the reasons why people consider a randomized control trial the gold standard, because the assumption is that randomization accounts for both measured and unmeasured confounding. The other thing I want to briefly kind of talk about is effect modification and interactions. So whereas with confounding, you adjust for it in your model and you don't report it, you're going to report if you have an interaction or effect modification. So if there's an interaction happening in your study, what that means is that the way the intervention impacts different levels of a variable is going to be different. So for this example, if you have men and women in your study and the impact on men is different from that in women, then you're going to consider there's an interaction happening. So for example, in the first panel here, what you're going to see is that there's no interaction occurring in this model. So both men and women are having an increase in the outcome when they get the intervention, and that increase is the same. And the way you determine if they're increasing at the same rate is by looking at the slope of this regression line. It's another reason why regressions are great, because you can get to visually inspect your data and visually impact if there's like interactions happening in your analyses. In the second column, in the second panel, what we see is called quantitative interaction. So that means the intervention is having the same impact on your men and women, as in they're both having an increase, but the rate at which the increase is happening differs. So in women, you see that the increase is much steeper than that than men. So that's a quantitative interaction. A qualitative interaction is when your intervention is having a different impact on the men and women or whatever groups in your study. So for example, you see it's causing a decrease in men, but an increase in women. And again, when you report the final results, if you notice there's an interaction in your study, then you need to report the estimates for men and women or tall and short people differently, because if you collapse it, they're going to have a biased estimate. Any questions? Okay. So once you've done your analysis, you've adjusted for confounding, you've looked to see if you have effect modification happening in your data, you're going to get your result and you're going to get a point estimate. And that's your measure of association, the measure of the association between your intervention and your outcome. With regression models, we get odds ratios, we get risk ratios. And again, this is just the example we're working with regression. So if you get like an odds ratio from your model, your odds ratio is representing the odds that an outcome would occur given a particular exposure compared to the odds of the outcome occurring in the absence of the exposure. And because it's a ratio, a value of 1 means there's no difference, there's no finding. And if it's greater than 1, then you consider to have either greater odds or benefit, depending on what your intervention was. And less than 1, you have a reduced odds. So just for example, if you look at the association between flutamide, this is something that reduces receptors for like prostate cancer. But if you got flutamide and your mortality is 0.89, it indicates that those who got the treatment had a reduced odds of dying. And so that kind of indicates an 11% survival advantage. And the way you calculate that 11% is you just say 1 minus 0.89. And something to note when you get your results from your adjusted model is that an association is not a causation. Your results can tell you that your intervention is associated with your outcome of interest, but it cannot tell you that your intervention caused the outcome of interest. If you want to speak towards causality, you really need to do different types of causal analyses in order to do so. The other thing to note is your point estimate, your odds ratio, your risk ratio, because it's just a single number, it doesn't speak to the underlying statistical variance in your estimate. And so in order to do that, we get our estimate, and it also is going to spit out confidence intervals. So, and it's going to spit out p-values, and we'll talk about p-values next. So your confidence intervals, as we mentioned earlier, indicates the precision of your point estimate. And usually if you have a wide confidence interval, so if your confidence interval is 20 to 105, is usually is considered that your estimate is probably imprecise. If you have a tight confidence interval, then that generally indicates that you have high precision. So when you think about confidence intervals, what they are is just, if your data collection and analysis was done over and over and over and over and over again, a 95% confidence interval would indicate that your interval will include the correct estimate about 95% of the time. So some examples would be, if you have an OR of 2.5, and your confidence interval is 1.9 to 2.78, you will look at that and assume that, and say that your result is significant because your interval does not contain the null value. So if you have a confidence interval and it contains a value of 1, which is your null value, so your interval crosses the null, then usually people would say that's not statistically significant. If you have an OR of 0.5 and your confidence interval is 0.01 to 0.22, also a significant confidence interval. If you have an odds ratio of 1.6 and your confidence interval goes from 0.8 to 3.4, this would be considered not statistically significant because this range contains 1, because you go 0.8, 0.9, 1.0. So it wouldn't be considered significant. To note, small studies usually have a less precision. And so that means that your estimate is usually subject to more random error. And this is one reason sample size is pretty important when you're studying, when you're planning your study design and like doing your power calculations. However, a large sample size doesn't necessarily fix all of your problems. And we're going to kind of get into p-values. So p-values are calculated in relation to a specific hypothesis, usually your null hypothesis. And we see p-values all the time. We love the less than 0.05 is usually considered statistically significant. And so a large p-value usually indicates that your data is consistent with a null hypothesis, and a small p-value usually indicates that your data deviates from the null. What your p-value does not tell you is the strength of your estimate. So a p-value doesn't tell you how big your odds ratio is or how big your risk ratio is. It doesn't tell you how accurate your estimate is. It doesn't tell you how precise your estimate is. It doesn't tell you whether your null hypothesis is true or false, and it doesn't tell you whether an effect was observed. And if you're working in a large sample size of like millions of observations, this is usually pretty easy to see because you can have an odds ratio of 1.1 and a p-value of 0.000001. And that's because when you have a large sample size, your p-values are often significant, even if your estimate is really tiny. And this is also one of the things that comes up when you talk about clinical significance versus statistical significance. Often you might have variables in your model that are statistically significant but don't have any clinical meaning. And again, that's something that you get input from your team on. And so so very often a confidence interval is more informative about your estimate and the precision of your estimate than a p-value is. And to wrap this up, there are some additional analysis considerations that we're not going to be able to get into too much detail today. But when you're doing a randomized controlled trial, there are usually 2 types of analyses you can do, either an intent to treat analysis or a per protocol analysis. Now, an intent to treat analysis basically analyzes participants as they were randomized. So if your participant doesn't comply with treatment, they drop out, they switch groups, it doesn't matter. You just analyze them as if they stayed in the group they were assigned to. And this approach preserves the benefits of randomization, and it kind of answers the question, how would my intervention work in the real world? How does it work in people with whom it was targeted? Because every patient isn't going to be your perfect patient. The other approach is the per protocol analysis. And this answers the question of how does my treatment work in like my ideal patients who come to every appointment, take their medication perfectly. However, you lose the benefits of randomization because you only keep the people in the analysis that did what they were supposed to do. And it can often bias your findings if the reasons for non-adherence or dropout of your study are somehow linked to your outcome, which then leads to the discussion around adjusting for confounding in randomized controlled trials. Now, as you remember, randomization is assumed to take care of both measured and unmeasured confounding. So some people don't think you should have to adjust for confounding in a randomized trial analysis. However, if you're doing a per protocol analysis, if you're doing a longitudinal study, if your baseline value is something that can change over time, it is probably makes sense to like just look for confounding to see if you need to adjust for it over time. If you're doing a cluster randomized trial, or you're doing a study where you're measuring people over time and collecting data on them at multiple time points, something you need to think about is adjusting for the correlation between individuals, between individuals, within an individual, and between clusters of people. And these are like mixed mixed method, not sorry, these are mixed models, and they're hierarchical regression models. So they have fixed effects and they have mixed effects. So for example, if we're doing a study and we're doing an intervention in several clinics and we're measuring this outcome in our patients over time, you need to do your model where you account for correlations within the patient and correlations between patients who, for example, see the same doctor, because there are obviously going to be correlations there. And these are just some additional concepts to keep in mind as you start to do more advanced regression models as well. So the next part of our presentation, we're going to show you some examples of some of these methods in action, and Nick is going to take over.
Thanks, Shana. So much to cover, so that was excellent, and I think taking something away from a talk that's quantitative analysis is sometimes hard, but I'd really point to, I think, your nice slide about the different outcomes. Often the statistical approach and how you measure these outcomes are mostly dependent upon the study design and the study question. So I think about the quantitative analyses after you've really done a good job designing a study that limits some of those biases, selection bias that you can introduce and that sometimes aren't fixable with fancy modeling. Modeling can't do everything, so it's all about study design, setting yourself up for success early. Next slide, please. So I think for implementation, we're often dealing with something that we are doing for patients, some new policy, some new intervention that we are implementing, and there's a couple of designs that are really well aligned with that concept of we're going to do something and we want to measure what happened before and what happened after for all of the important implementation outcomes. And so those designs are often robust in terms of what they can tell you. They for example, RCTs, like cluster randomized trials, are inherently resistant to those confounding items that Shannon talks so much about. And quasi-experimental designs, which are often also termed econometric designs, are also relatively resistant to some of the important confounders we think about. And so I'm going to talk just through two examples that use this quasi-experimental design. I'm not going to go into the details of these designs. That's been covered in a previous education seminar, but I think it's important to know that these kind of two buckets of study designs are really well suited to answer implementation science questions rigorously, and that the specific approaches differ from an analytic standpoint. But I think I would encourage everybody to really think about, especially if you've already done an implementation, quasi-experimental studies, because you don't have to prospectively randomize somebody. Okay, next slide, please. So the first one we're going to talk about is implementation at Boston Medical Center of using phenobarbital to treat severe alcohol withdrawal in our ICU. And the method we used here was an econometric approach called interrupted time series, as well as some other analyses. Next slide, please. So what we were interested in doing is at the time, patients who were being treated with alcohol withdrawal were receiving a protocol based on some medications called benzodiazepines, and there was anecdotal concern that treatment regimen was potentially harming patients, leading to them requiring a breathing tube because of medication side effects. And so we were interested in trying a different protocol that we thought would be better, implementing a new protocol, and studying whether this new protocol was agreeable to our staff, our clinicians, our nurses, our pharmacists, as well as studying whether it was not worse than the prior one for patient outcomes, because our focus here was on non-inferiority, making sure that the patients weren't harmed by changing this protocol. And so we had two components of quantitative analyses. I'd just like to make a comment about surveys. Surveys, I think, are sometimes people confuse whether they're quantitative or qualitative. They can be both, but most surveys, I think people think of as being quantitative, that those, when you respond to a survey, especially a Likert survey, which I'll show you next, those are outcomes that can be measured with some sort of central tendency measure, like a mean, median, something like that, as well as you can compare using a statistical test that compares survey results to each other. And then we also collected and reported patient outcomes, which I'll get to. Next slide, please. So this is an example of one question from this survey that we did for this study. This is called a Likert type scale, meaning that the responses are ordered, right? You can disagree, strongly disagree, neutral, agree, strongly agree. But there's not clearly that strongly agree. How much better is that than agree? It's not clear. And so that means that this outcome is called an ordinal outcome. It has some, the outcome results have a relationship between each other, but the distance between those is unclear. Okay, you can expand the rest of this slide. So these are Likert-based responses. Yep. And so some of the decision when we wanted to provide a survey to our nurses and clinicians to ask their understanding about treating alcohol withdrawal before and after this implementation. And some of the analytic decisions we were interested in is we were interested in pairing each individual's response before to a response afterwards. So that paired nature, I think as mentioned by Shana, when you have this clustering of outcomes because they came from the same individual or from the same hospital or from the state, has to be accounted for in analyses because those are not independent answers, they're related to each other. So we had to think about that paired analysis. We thought about how we want to approach measuring this ordinal outcome. And what we ended up doing was actually we dichotomized it mostly for efficiency's sake. But what that means is we were interested in saying whether you agreed or anything else. So if you strongly agreed or agreed with an answer versus everything else. And that was a post-survey decision that we made in the analytic stage. And then here is just the sentence in our manuscript on the methods about surveys that we use the McNamara paired test. And knowing that specific test, I think, is not important. This is kind of a choose your own adventure. Once you know the outcome and you know the decisions and the study design and the fact that you have to do a paired analysis, you can look up on Google or many helpful websites to find out what the right test is to compare. Next slide, please. And so what I'm going to do next is I want to drive home the point that this is formulaic and it sounds I think intimidating when you read method sections and read the results section. And I just want to break it down a little bit to help make it clear that this is often like a Mad Lib, right? Where might write we used model X, and the X is where you fill in the blank. And that's a lot of what the statistical analysis sections are, and the results section is they have a formula to doing a study and also to writing up the results. Okay, next slide. So this is just the results from our survey, and what you're going to see is a common theme here in red. You always are going to be reporting who are the patients, how many there were, and what were their characteristics. And that's, classically in a randomized trial would be a figure 1 and a table 1, but it's true in every single study. So for the survey component of this study, we sent out the survey to 241 clinicians, got a quite low response rate. And this is why I don't want to focus too much on the surveys, but we got 39 people who completed both the pre and the post survey. And then we said a little bit about them. And then what usually comes next is some measure of what was the outcome. And so in our case, we had a dichotomous outcome. And so for this blue is for one question, whether responders to the survey were concerned about the risk of a breathing tube for treating alcohol withdrawal. And we found that decreased from a percentage. So this is just, what percentage of these 39 patients said this, 77% to 26%. And it's usually followed by some test of whether those numbers are different from each other. And in this case, they were. And there really should have been confidence intervals here too. Providing a p-value without confidence intervals is a little bit frowned upon these days. All right, next slide. Great. And so for the patient data, we wanted to understand the safety and effectiveness of this new protocol to treat alcohol withdrawal. And because the old protocol, we were concerned about the breathing tube or the mechanical ventilator, we wanted to study the same outcome here in the new protocol. So our primary outcome for patient safety was mechanical ventilation initiation, need for that breathing tube. And we approached it from a non-inferiority standpoint, meaning that we were okay with a small amount of outcomes being worse if everything else was better in terms of the protocol. And we were interested in comparing outcomes before and after the intervention. And anytime you see, I think, before and after, the method that you should be applying are one of these econometric approaches, interrupted time series, difference in difference, mainly those two, because they account for many of the confounding factors that can be so problematic in a typical before and after intervention. And that's mainly changes in the outcomes that were happening independent of your study. And I think the easiest example is you implement something, but before you implement it, you were hyping up everybody, right? You were engaging with stakeholders, talking with various people about why this is important. And those efforts can actually change the outcomes themselves before you've even implemented in something. And so econometric approaches help to account for those pre-implementation things that may be changing that aren't, that when you test post-implementation, you could spuriously conclude that your intervention worked when it was actually just all the prep work you did. So what we did from an analytic standpoint, we were interested in accounting for these confounders. That's why we used interrupted time series. Our outcome variable was dichotomous. Yes, no, did the patient need the breathing tube? And then here's what we wrote in the method section. We almost always write, you calculate some summary measures at baseline, age, what illness someone had, all of those demographics and important clinical characteristics, and using means, medians, percentages. And then I'm not going to get into the detail, but we use an interrupted time series approach. Next slide. And so then this is what we wrote. Again, in red, it's how many people were included. So this is your assessment of who's the population that you're interested in. And then in blue, we reported just the percentage of people per month, and you can see it in this graph here, that experienced the outcome. So unadjusted analysis, no comparison, just reported the number of the percentage of patients who experienced the outcome per month. And I think a very important part of thinking through quantitative analyses is how you're going to present the results. Figures are key. A good figure can paint such a good picture of what's happening that a bunch of words sometimes cannot. And so thinking about how you're going to do a visualization for your quantitative analysis is very important. And then the results of the study, the main takeaway here is this difference here. And so this case, we have a statistical test, which is actually implicit here. The p-value is not here. We decided not to report the p-value. That's becoming more and more common. We did report the 95% upper confidence interval, which is how we know whether our non-inferiority test, whether it was worse, better, or similar to the prior protocol. That's this estimate. So here's the effect estimate of negative 4.9 in green. And that means that compared to the old protocol, there was a negative 4.9% absolute risk difference in mechanical ventilation compared to the old protocol. And the confidence interval is 0.7, and that was below our non-inferiority limit. Next slide, please. And then the next study I'm going to talk about is measuring outcomes for adoption. And so this is trying to understand if once we know a treatment or some sort of intervention works, how do we know if it's being adopted by people into practice? And so I'm going to go over this study. Next slide, please. So here for this study, the motivation was this study that made all the news in the world from the recovery group in 2021, early in the COVID pandemic, that showed that the steroid dexamethasone given to severely ill patients with COVID-19 could reduce death. by a lot. So a relative risk you can see in the forest plot within the box there shows that triangle, that white triangle, shows the overall effect for the randomized controlled trial, an efficacy RCT of 0.8. So it worked. And so we wanted to understand, well, does this work in the real world? It worked in a clinical trial. And so that's what we set out to understand. Next slide, please. And so here we were interested in measuring adoption. So in the case of adoption, we're not as much interested in, well, was death different? We were interested in, were people using corticosteroids? And so you can think of adoption many ways. You can think of, as we did here, as yes, no, did a patient who should have gotten steroids, like they would have fit the criteria for the recovery trial, but they were in the real world, yes, no, did they get corticosteroids? But you might also think of it as how many days of corticosteroids. So you can come up with different ways to measure adoption. But in this case, we were interested in yes, no, were they at least started on it? Again, you could consider whether that starting it was the right dose or the right number of days of treatment. Those are all interesting study questions that could have also been assessed. We were interested in looking at between hospitals. A really powerful method is understanding how adoption and practices differ between hospitals. And then you could identify those hospitals, go to those hospitals, do a positive or negative deviance study to understand what are the factors that drive different levels of adoptions. And so looking across clusters of healthcare settings is a powerful method. And then the second step was this study was if hospital systems were adopting steroids into practice, did that change patient outcomes? And so in this case, in the manuscript, we used what are called linear probability models, which is really just a linear regression. So one of those modeling types that Shana spoke about. And in this case, we ended up doing a difference. We adjusted for some factors, and we also did a difference in difference method. So I'll show that in the next slide. So here is adoption. Again, visualization of quantitative results is so key. So on the left-hand side, ignore the who was included in the unadjusted outcomes for a second. On the left-hand side is the takeaway. Each on the x-axis here, so each pair of dots corresponds to a hospital. And the red dots corresponds to the rate of corticosteroid prescription in the pre-period before recovery, and blue is afterwards. And so you can see on the left-hand side of that graph, there's some hospitals that were never getting steroids before and then had a huge increase in their use of steroids afterwards. And on the right-hand side of the graph, you can see that there are some hospitals that already were using steroids before recovery and then just kept on using them. And so by comparing, so you could see that there's a huge amount of variation in practices before and after adoption. And we might identify some of these hospitals that we were interested in learning more about. Maybe we go to a site, do some semi-structured interviews. And so you could imagine how a graph just as simple as this helps you pinpoint different areas that could need improvement or are already doing things well. What this is also described in the results. And so we did, just like the other study, we said who are the patients and who are the hospitals. So there's 34,000 patients, 600 hospitals. Who are the patients? What characteristics do they have? And then on average, so here we just rather than stratifying corticosteroid rates by hospitals, we just provided one summary measure. So overall, 42% were treated with steroids before, and then afterwards it went up to 94%. And so that, although is a helpful measure, stratifying these results by the hospital gives us a lot more granularity, a lot more data to understand adoption patterns. And I think one more slide. And then lastly, measuring effectiveness. So we took advantage of hospitals that were already using steroids and those that weren't using steroids and then started using steroids to do this method, difference and differences, to find whether or not adopting steroids into practice improved outcomes. And I think we're running short on time, so I'll just say that it did, that there was a negative 8% in green absolute risk reduction in death among those hospitals that adopted steroids after recovery, which is very close to the estimate found in the study. So in this case, often unlike other items we found, the efficacy clinical trial matched very closely with the real world effectiveness. And is that it? And I think that's it. So quantitative analyses are a huge subject, and I think it's hard to do all of the nuances of this justice in an hour. I think when you're the takeaways here are when you are planning a study design, it's important to think through what are the risks to the validity of your study. Those are mostly biases that either you can introduce by designing a study incorrectly, which I think is the most important bias to minimize, but also biases that are intrinsic to any study, especially observational ones like unmeasured confounding. Those you can kind of take care of in the analytic phase, but I think the study design is the important key to minimize those biases. Quantitative measures give you an idea of the effect of what is happening, what's the measure of central tendency and the variation around that, and the certainty in our estimates. That for statistical analyses often are kind of cookie cutter, that when you have a study design question, you can often find the statistical test and approach that matches the study design and the outcomes that you are interested in quantifying. And just a note that association is not causation in all of the modeling in the world. So even what are called fancy machine learning models or causal inference models, you'll hear that a lot, a causal inference approach. That does not mean something's causal. That means that that model is designed in a framework based on causal inference. But causation, it goes back to the root of study design, Cox postulates, randomization, repeating and getting the same result over and over again. That's causation. So we should be avoiding referring to any of a modeling technique as being causal, because it's not. That's it. Our next session is coming up on March 14th, and we'll take any questions.
Yes.
Sure. So there's a question in the chat about talking about adjusting for mediators or confounders. And so this goes back, I think, to drawing this DAG. I put this in the chat, a direct acyclic graph. So traditionally, we think of confounders as a way to identify an independent, quote, independent effect of an exposure on an outcome. But relatively recent advances in causal inference have made us realize that sometimes you can over adjust, that you can adjust for things that you shouldn't be adjusting for. And so there are many of those things. There are things called colliders that when you adjust for them, variables that you adjust for, you can actually get the wrong answer rather than the right answer. Mediators are related in some ways and not others. So a mediator is often, I think of like the mechanism by which something happens. And so you might expect that steroids reduce death, but in the middle of that is that steroids work by decreasing inflammation in the lungs. And so a mediator in that case would be whether or not is inflammation in the lungs. And sometimes you can measure those things and sometimes you can't. And mediators are often hypothesized, right? You hypothesize that there's a causal relationship between multiple variables, and you can use modeling approaches to quantify how much of an exposure, steroids on outcome death, go through that mediated pathway. And it's a little step beyond classical regression, but not that many steps. So I think it is very important for implementation science, where often we have these intermediate outcomes. Maybe we're not knowing whether vaccination improves death, but we want to know if a vaccination implementation initiative increased vaccination. That's your mediator, right? And so having those intermediate outcomes as mediators is a great thing to capture, and you can then quantify whether that mediator is the hypothesized mediation between exposure and outcome. Anything to add there, Shannon?
No, That was great. And I would add to Nick's point about drawing DAGs, because DAGs are also a really great way to see if there are mediators in your study and really help drive any mediation analysis that you would then need to do.
Journals are asking for DAGs now, and they can be done by any content expert, a clinician. They don't require statistical expertise. They require a knowledge of being able to draw arrows and some rules, but they really help to minimize making some mistakes that you otherwise would by conditioning or adjusting for a mediator or a collider.
Any more questions? We have a question in the chat.
Yeah, so I think this question is getting around in a small population, can you ever make any assumptions about normality, right? So parametric means normal distribution, and I think that's right. That in general, you need a large sample to use parametric tests. So in general, I think that's true, that using a non-parametric test. So the parametric versus non-parametric statistics has for a long time historically, statistics was grounded in parametrics tests. So tests that rely on assumptions. These are all assumptions, untestable assumptions, that the data has a certain distribution. And if we think the data has a certain distribution, then even if we don't know the truth, we can estimate that truth because we know what the distribution should be. And those assumptions start to break down when you have very small sample sizes. And so you have to use other tests, non-parametric tests, that are not based on those same assumptions. They have their own assumptions, but not the same assumptions, because on small sample size, you can't necessarily rely on that parametric assumption. And again, that's one of those things that you can look up. You know, you have 10 patients, you have an outcome that's continuous, ordinal, dichotomous, etc. What test should I use? And often, especially for things that are commonly tested, like length of stay. Length of stay is a notorious outcome that's hard to model, but there's many studies that have looked into this, and you can find a study that said this is the right way to measure length of stay.
And often, even when you have data, continuous data that's not normally distributed, there are also other techniques you can use to account for that, categorizing it, log transforming it into a different types of log, transforming it. And again, that's also something you can put into Google, and it will pop up the different ways you can transform your data if it is not normally distributed. We have 2 minutes, and I want to encourage everybody to also take our quick survey. We really rely on your feedback for these presentations. We want to make sure that we're sharing information that is useful and presented in a way that you find easily digestible. So please take time to fill out our survey for us. Thank you, everybody.